Good evening, everybody, and welcome. Thank you for joining us tonight. I'm James Galt, VP of Product Development at Forma Medical. We're joined tonight by two distinguished foot and ankle surgeons who have been early adopters of the OptimalMTP MIS plating system and have each developed their own approach to utilizing it. We'll hear about their experience, patient outcomes, and the techniques they developed. First, we'll hear from Dr. Christine Seaworth of Knoxville Orthopedic Clinic in Knoxville, Tennessee, who will talk through a bit of the history and her journey going from open to MIS MTP fusions. I'm also excited to welcome Dr. Erroll Bailey of Resurgence Orthopedics in Atlanta, Georgia. He will first cover a bit of the literature, his journey, and we'll take a deeper dive into procedural insights and outcomes he is seeing in his patient population. So one of the questions we hear most often is why? Why change your approach to MTP fusions when fusion rates are already high? And it's a great question. The answer to this is something I hope listeners can take away from this webinar. Our perspective is that first MTP fusions don't have a union problem, they have a healing and patient experience problem. Today, many surgeons perform minimally invasive bunion procedures, yet essentially the same anatomy transition to an open technique for MTP fusion, and this creates a disconnect in the patient experience. The impetus behind OptimalMTP was to help surgeons deliver a true continuum of care, enabling MIS treatment across deformities and disease states without asking you to compromise on the construct you trust. So if you're performing MIS bunions now and you haven't yet made the leap to MIS MTP fusions, you are not alone, and even better news, you're in the right place. So thank you again for being here. And with that, I will turn it over to Dr. Seaworth. You should have control now, Dr. Seaworth.
Hello, good evening, y'all. I'm located in Knoxville, Tennessee, as James has said, and I'm in private practice at Knoxville Orthopedic Clinic and do a little bit of work at the academic center as well at UT Medical Center. This is here looking at me in my, let's see, it's not going forward there we go. This is me, this is just me in my private practice view, but some of you may also know me because I went a little viral on TikTok, and that was back a couple of years ago for my turkey carving safety tips. So if you're curious, look me up. Now on to the main topic tonight. We all know some of the indications for first MTP fusion. They're advanced hallux rigidus, severe hallux valgus, and if they failed chylectomy or arthroplasty in the past, this can be a good option for our patients to help them with pain control and to get them back and moving. I like to sometimes go back and look at some of the historical treatment when I'm considering, what to do when I'm looking at a new problem. And initially, this was first written up in 1904, and it was with Keller excisional arthroplasty was really the standard of care way back then. Overall, patient did well, but as we know, there can be problems with cock-up toe and transfer metatarsalgia. We've moved on. We've developed celastic implants, as you can see in one of my x-rays here. This patient also had a Lapidus procedure as well, interestingly enough, and was pretty young when she came to see me for a different issue. And also interpositional arthroplasty. Again, these have some issues and some complications in the long term. And we've also tried hemi and total arthroplasty of the joint. Some of these do amazing, but some of them have issues with loosening, subsidence, malalignment, as you can see here in this x-ray as well. Also, in regards to surgical treatment, in regards to first MTP fusion going way back, they initially started by using an ivory peg, and that you can see there on the left picture. This is looking at a femur, so to give you a little bit more detail, but I thought that was really interesting. We've gone on to cross screws, and modern, really the standard of care at this point is dorsal plate with a lag screw, and we've all been tested on this at some point. Looking back at a biomechanical study that's not too old from 2023 with Sam Adams, they did test several different constructs, and the dorsal lock plate with a compression screw, as we know, is the most stable construct, higher stiffness and load to failure. And they also found that lock plates have less plantar gapping, which can be important for weight bearing and progressing activity. But they did note that more research was noted for exploration of new implants and techniques. Clinical outcomes of fusion, we know this does really well, which is one of the things that we think about when we're like, why change? Why should I do something different? Plates and screws are reliable. Hardware removal is really uncommon, and overall patients do well with good pain relief if they're positioned appropriately. Factors that can go on to non-union, which I consider one of the biggest risks of the surgery or wound breakdown. If you have a higher pre-op hallux valgus, if you just have crossed screws, and different types of prep can make a difference as well. And also, we all have a lot of patients that have a high BMI at this point. When we think about the gold standard, when we talk about the dorsal plate with cross screws, we think about an open approach. We talk about the cup and cone preparation with the reamer, improves contact. You can dial in your alignment, but you can also see it has this very large open wound with a lot of soft tissue injury and stress on the joint. So maybe this isn't the best approach. We think about MIS, we're using it in lots of different techniques. And I asked myself, I'm doing lots of different MIS procedures now, heel slides, bunions, hammer toes, hindfoot fusions. So why am I still doing open MTP fusion? And so patients are thrilled about MIS. So I'm thinking about how can I expand my portfolio and different offerings to patients. And I'm just trying to think about also how can I challenge myself? And again, what more can I offer to my patients? Don't be left behind. So looking around, I think the great toe is another great place to work on MIS procedures. And the minimally invasive first MTP fusion, there was a study back in FAI in 2024. There was 41 open, 26 MIS. The fusion rates were similar, about 95%, and complications rates were the same as well. You can see here looking, just like I showed you in that other picture, the incision is quite large. And yes, it's usually a little bit smaller than that. This patient had a lot of soft tissue, but it's still much bigger than an MIS approach. This is looking at some of the different portals that you can use as well when you're doing your MIS approach. So I decided it was time to try MTP arthrodesis. We think about the toe, it's stiff, it's painful, it sometimes has a large bony prominence, as you can see in this picture here. And historically, when I've done fusions in the past, they've done very well with my plate and screw construct. I feel good about it. I know it's tested on it, and it's biomechanically the strongest. So what can I do to mimic that approach, but do it with the MIS technique? I knew I was not going to be putting down a frame, though. So the Forma Medical plate, the OptimalMTP fusion plate, really allows you to stick with what you know is familiar, does well for your patients, and biomechanically is very strong. It allows minimal incisions. I have started doing these without tourniquet. So, there's a lot of people out there that believe the pain is less. You don't have tourniquet pain. They may not have as much difficulties with reperfusion. So I'm doing that without tourniquet. And the tray also comes with plates for an open approach. So you always have a bailout option if the MIS procedure is not going well, and you can convert to what you know and love. Intraoperatively, this is an x-ray of how you help put on the K-wires, and you can pick and choose which screws you want to do first. They do have K-wires. There are also olive wires in there to pull the plate down to the bone. One of the things we'll talk about, but just to notice on this x-ray, is that as you come in with the burr and you're prepping the joint, you get a little bit more of a flat surface. You can see it takes away a little bit of that flare of the base of the proximal phalanx, so there can be less footprint to be able to put in that cross screw. So maybe better to put the screw from proximal to distal instead of distal to proximal, as I've traditionally did with an open approach. So just something to look at there on that x-ray. My very first case I did was a 73-year-old retired internal medicine physician. He'd failed conservative care with another physician, came to see me, was healthy, compliant, just a sweet old guy. I think one of the other things, too, that ended up being nice that I didn't even think about is that he didn't have a large dorsal osteophyte. So there was one less thing that I had to worry about with this surgery, and I only had to worry about the joint prep. So at 3 months, he has minimal swelling, no pain. He does have pain at the base of his second toe there. We can see some early subluxation and metatarsalgia. He's walking 3 miles a day. And overall, he's doing very well. His pain is limited to his second MTP joint. That's really what's holding him back. The hardware all looks stable. I think there's good healing medially. You can see that the healing laterally is maybe still a little slow, but I think this is a very stable construct, and I would consider this healed because of how well he's doing and no signs of loosening with how active he's being at this point. We're also, Dr. Bailey will bring this up later too, but the MIS procedures just tend to heal a little bit differently than our traditional open procedures. My second case, felt that one went really well. So then the next time I did it, I actually scheduled three in the same day so I could do them back to back to back. And I decided to add another variable to make it a little bit harder. I added in the hallux valgus. She was very stiff. And you can see on the lateral there, she definitely had some loss of joint space and some small osteophytes. So we were dealing with the hallux valgus and the hallux rigidus. The MRI did confirm the arthritic changes as well. Initially, her surgery was denied, and she's definitely angry at United Health because of that. So we finally got it approved, and I was able to do the surgery twice as fast as the first one I did. It went very smoothly, got excellent fixation. I was feeling very good about myself. She had no pain, back to full activities at 3 months, and has no complaints. And unfortunately, she's still unhappy at United Healthcare, but she likes me. This is my fourth case, actually. So I decided to go even bigger on my bunion. That was that same day. Later in the day, I was feeling good about my other cases, and she was extremely stiff as well. And this is where I struggled a little bit. One, I thought I was getting a little better, maybe didn't go quite as slow, but she had also a very soft bone, a very severe hallux valgus angle, which can sometimes be very difficult. I could not get the hardware to sit appropriately. I just couldn't do it. So I converted to open, and the tray had everything I needed. And this is her at 3.5 months, and she did great and is really happy with her outcome. You can see here on this x-ray here how the plate sits on an open. You can see it's very low profile and sits down to the bone, so it's not prominent, so that's not something to worry about. Also, another surgical tip, like we talked about before, you end up with like some of not having enough bone to work with here at the proximal flare on the hallux. So you may want to go from distal to proximal with your screw. Also looking at the drill, this is the larger of the two cannulated drills. There's a large and small. The large is used as to countersink. I would not do that unless the bone is very hard. You don't need to countersink if the bone is regular to soft, just only do if it's hard. So that's another surgical tip to get good fixation and compression with that cross screw. Here's my last case I'm going to show you. This is a 57-year-old female, and at her 6-week appointment, you can see there with the blue arrow, it was completely healed. The joint was healed. She was back doing all her things, and I let her weight bear at 2 weeks. I've been very conservative in the past. I've made people non-weight bear for 4 to 6 weeks, as I was taught in training. So as I get better with this, I'm getting more aggressive. The other thing that on this procedure, you can see there on the top x-ray is that she had a loose body in the joint and a large dorsal osteophyte that I was able to take out from that medial portal. After I'd gotten more comfortable with preparing the joint, I added that in and just came over the top of the metatarsal head and smoothed all that down. It went smoothly. Now I'm going to turn it over to Dr. Bailey out of Resurgent Orthopedics in Atlanta, Georgia.
Nice job, Christine. Erroll Bailey, Atlanta, and I'm glad to be speaking to you this evening. Let's see if we can get ourselves moving forward here. So, as Christine talked about, why do this? Well, I have found this to be extremely helpful in patients who have connective tissue disorders, rheumatoid arthritis, lupus, those people I'm concerned about that may have wound issues. Also, people will present with poor skin and other reasons for having concerns about wounds, and I found this procedure to be very helpful in those people as well. Also, pain management patients who come in telling you that oxycodone will be just fine, doc. When can I have some of that? I tend to err on the MIS side with those patients as well. Smokers too, okay? And as Christine had spoken about earlier, for the hell of it, to learn something new and to challenge yourself. So my very first attempt at this was about actually 6 years ago now. I had a patient with pyoderma gangrenosum, and if you're familiar with those people, they pus everything out everywhere whenever they're touched and whenever hardware is put in them. And she had a or a slow healing ulcer from dorsal osteophyte on her foot. You can see the ulcer there on the left. and she was having pain as well. If she had just simply had the ulcer with no pain, I would have done a simple MIS chilectomy, but she was hurting from her arthritic joint. I did not want to open that because she had pussed out even a knee arthroscopy prior. So I went the MIS route. And when I did that, I first did small incision dorsally and did a dorsal colectomy. On the left, you can see where I've removed the dorsal osteophyte, and then from the small incision medially, I prepped the joint. You can still see some of her superficial ulcer dorsally. I fenestrated the joint and then went on to place two cross screws across the joint and got her to heal. And on the right, you can see those incisions. She went on to do extremely well for about a year and a half until she pussed out another joint and then infected this joint. And then I had to remove the hardware and put a cement spacer in. But that was not on me. This was a successful MTP fusion at the time. What's the literature show? Well, here's a meta-analysis study. 6 studies combined, 108 MIS fusions, 106 patients, about a 90%, 89% non-union rate. Some people did go on to get some IP joint arthritis, a revision rate of about 5%. And basically, the conclusions were that this was comparable to open. This is Chris Miller's study out of the Boston Beth Israel Hospital, where they compared 51 open procedures to 29 MIS procedures. And basically, the MIS procedures actually had a higher fusion rate compared to open, but they did have some hardware issues, and 5 of the patients had to have hardware removal. And the open patients, there were 5 patients who had dorsal scabbing or wound issues or got infected. Once again, basically, at the end of the day, the results are pretty comparable, except with MIS, you have the advantage of less pain, you have the advantage of a better cosmetic result, and these can go on to heal faster. And this particular study, you can see that the average or median time for fusion was at about 5 weeks or 4.9 weeks. I have not seen that myself. I have seen them to be clinically healed at 5 weeks, but not necessarily radiographically healed. And these do heal differently. If you've done MIS bunions, you know, sometimes your patients are 100% pain-free and you're not quite sure based on the radiographs if you've got union or not, but they're walking 4 miles a day and playing tennis, so you know they're clinically healed. The same can be true here. If you're looking for complete absence of a radiographic line, sometimes that may not happen to week 10 or week 12, but clinically at around week 4 to 5, they really don't hurt anymore. This is a case of mine. This also highlights Jesse Doty's study and foot and ankle spec in 2025, which shows the technique and how this actually works. So I was able to do this patient MIS despite the hardware that was in. The screws were stripped. I couldn't get them out through the small dorsal incision. I decided to leave the staple in. I was able to debride the joint through the medial portal and also place a compression screw across and a dorsal plate and miss the hardware. So that was actually fun and pretty neat. So how do I do this? Well, Forma has a nice jig and a complete system. I do a ton of MIS, and I've done it with the jig, and I've done it without the jig, and I'm more comfortable doing it without the jig, although the jig indeed is wonderful and works. So the way I do this without the jig is I locate my portals. Portal A is going to be where you're going to introduce your subperostal elevator and also put your burr in. Portal B, if you've got dorsal lateral osteophytes. Those are hard to get from portal A. And so this is a nice portal to go for those. Also, as Christine alluded to earlier, hallux valgus patients can be difficult, and a lateral release here can help reduce the MTP joint. Portal C is where you're going to basically do your chilectomy through after subperostal dissection. So here I am. You can see I'm distracting the toe. You can see portal A where I'm making an incision, and I go in and do subperostal dissection, and then I introduce my burr, and I introduce it with the toe having some pressure distracting the joint. It's not necessary to put a distractor on to do this. I then take a 2 by 20 millimeter burr, go straight across on my metatarsal head first. And basically, when you look at the met head, of course, it's ovally shaped. And right where that portion starts to end and the head can become flat, that's where I stop with my burring. So first create a flat surface. Some people will use portal A and portal B to keep the round shape of the head and to only get down to subchondral bone. That is absolutely fine, but I have not found significant shortening with the way that I do this. So I flatten the head slightly down to where I'm just distal to the sesamoids, and then I introduce my burr. And the motion is just a sweeping up and down with the toe extended. And you'll be able to see that on your radiographs as well. The burr's in, you'll create this slurry. You can see where a metatarsal head is flat, and you can also see on the proximal phalanx side, I've burred down just till you see that subchondral scar, that subchondral line. I don't go any further past that. Also, you can see that on the metatarsal head, there's a nice entry point for my screw, which I'll show you where I put that in later. Now, if the patient has some significant cartilage left, I will suck out the contents because I do believe that cartilage is the anti-fusion thing, and I don't like to leave cartilage in. If they're bone on bone, I don't do this. However, before I do my final fixation, I will put the burr back in and create some bone slurry. So some of that graft stuff is in there. You can see here on the third slide where I'm fenestrating the proximal phalanx and also fenestrating the metatarsal head. Following this, I will get my reduction. If the reduction is hard and you can't hold it, one of the tricks that I've learned that if I make my entry point where my knife blade is and I put my K-wire through, if you drive the K-wire straight till it's dead center in the head and stop, wherever you reduce your MTP fusion or your proximal phalanx on the metatarsal head, you can then drive this screw straight across, and it's always going to come out in the proximal 1/3 of the phalanx. You don't have to try to aim this all across in one stab. Another trick is that these will tend to leave a little bit of a plantar gap. So in the lateral plane, I will have that wire aimed for the plantar 1/3 of the base of the phalanx, such that when I get my compression, if there's any plantar gapping, this screw will close it down. You can see here on the far right where I am preparing for the screw head and countersink. Once I depth gauge and I like what I have, I drive that wire all the way through and grab it out the other end of the toe, because the last thing I want to do is lose that wire. I place my screw across, and then I will place another provisional wire out of the way, and I'll tell you why I do that. Is because next I'm going to put my plate on the top of the skin. I'm not using the jig here. And I locate it under fluoro, far left, and I see I'm gonna want that plate right there. And then with a marking pen, I mark the pinholes. After I do that, I will simply connect the dots with the pen, and those are going to be my incisions. The third view here, you can see I'm subperiostally dissecting from proximal to distal, okay, through that proximal hole. If there's a dorsal osteophyte, I will get it then by putting your burr in under the HL, under the capsule, and sweeping medially and laterally to create a flat surface for your plate. After I do this, I will come from distal to proximal to connect the opening for the plate. And I do this so that I don't distract my joint. Uh, I've got good screw fixation, but if I dissect from distal to proximal, I'm actually compressing that joint, and I don't have to worry about dislodging any of my fixation. As you can see in the far right, through that proximal portal, you can not only do your colectomy, but if you're subcapsular, you can also reach around and get some of the medial eminence, although you can also get this through your screw hole as well. Now I put the locking tower on the plate and I simply slide it subcutaneously under the skin. One of the things I've noticed is that you have to really subperiosteally dissect medially on the phalanx area because the plate will tend to slide lateral on you because there's not a big enough pocket medially. So I'll make sure that I do that dissection pretty well with the elevator on the medial aspect of the base of the phalanx. I simply slide it under. I get the X where I want. I take a K wire and I place it proximally through the locking tower, and then through the distal hole, I'll have my assistant simply hold the EHL out of the way. I'll grab the plate with pickups, put it where I want it, and then put a plate tack down it. And once you're here, you're pretty much home free. The rest is simply putting your locking towers in and finishing with your screw placement. And at the end of the case, it will look something like this. This is one of my earlier ones. This went on to do well, but you can see that the plate is about a millimeter or two dorsal on the metatarsal, and that's because I didn't effectively do my colectomy and remove all of that bone to create a flat surface. The patient went on to do extremely well nonetheless. So, which ones do you do this in? I would not recommend a big bunion for your first case because those are extremely difficult. But if you've got someone like this who was a 55-year-old teacher with a non-union from 2 wires, this lady came to see me. Why would I ever open this? I simply don't have to. The 2 K wires were easy to remove. It's a straight shot. Burr went right in, created the bone slurry, pushed it out, reduced it, and this lady went on to heal beautifully and was in her tennis shoes at 5 to 6 weeks in a pair of Hokas, doing extremely well. So there's just going to be instances that once you learn how to do this technique, that you'll start to find more and more reasons to do it. And it really, really works. It's changed my practice. I don't open MTPs anymore unless there's abundant hardware that I can't get out or that I can't dodge. Very successful, very happy. Patients love you. They're off narcotics typically on day 2. I let them walk day 1 in a Darko heel weight bearing shoe. It makes it so much easier on their lives and their husbands and wives at home that they don't have to stay home and stay with them because the patient is non-weight bearing. Here, I let them walk very early. I've been very happy with what we've done, and that's all I've got, folks. And so I just want you to all make it do what it do, and we're open for any questions that anyone may have.
Awesome. Thank you both very much. I think the last slide here is just a couple questions that I prepared that these are the questions that we hear most frequently from surgeons. So this one, I think you both covered this very thoroughly. Why change? My union rate's already strong. Is there anything else to add to that, Dr. Seaworth?
I think one of the things that I think about, and I only touched on it briefly, but if you've been doing the surgery long enough, we've all had a patient where the wound broke down. It's devastating, takes forever to heal. It's a lot of wound care, doesn't do well. So I think that's one of the reasons. I think that the other reason is that patients expect more than they used to, and they know that there's minimally invasive techniques out there. They're wanting them, they're looking for them. And why would you put them through a bigger, harder surgery with more recovery if you could offer them something better?
I want to piggyback on that and reiterate some points. One, these people have little to no pain. You should always want that, I believe, for your patients because it dramatically reduces their narcotic intake uh, dramatically. 2, you can walk them right away, just like with the open procedure in a heel weight bearing shoe. Um, so, uh, and for those who are a little gun shy here and have had some MIS experiences that they may not have liked, this is an easier procedure technically than a Chevron Aiken procedure in my hands. Do you feel that way, Christine?
I think so. I will say that I generally do a transverse cut when I do my MIS bunion, so I'm not trying to do, but there's less fiddle factor in the sense that you're not trying to figure out how much do I shift the bone, how much correction will I get, do I have to do an Aiken? So I do think it's a lot more straightforward, and it's very easy to watch the burr under the X-ray as it debrides. Another thing I'll do is take an X-ray before I start. So, and move it to the other side of the screen, on the split screen. So I have something to look back at to see what I'm doing, what I've done, make sure I'm not going too far, but also to kind of give me some guidance on how much I have to debride.
Excellent. That was great. Thank you very much. Next question here that we get a lot. Will MIS add operative time? So it's going to take me longer.
Well, I think initially, absolutely, yes. Anytime you do a new procedure, it generally adds time because as we go, we just get more and more efficient every time we do something. That's just our nature as surgeons. And anytime you add a new procedure, there's going to be extra time. You're going to have to be more careful, be more attentive, use more mental energy, and there's more fiddle factor. But the question is how quickly can you adapt to that, and how quickly does that start to turn over and turn? I think within about 10 cases, you're moving along pretty well. It's not something that takes, 50 cases to be very slick at.
I agree. And I might add that I think with this, it just really might not even take 10. I mean, the growth curve on the second and the third, in my experience, was fairly dramatic once you figure it out. The joint prep is something that I would encourage if you get in the lab with Forma, that you prep the joint, put your screw in across, put your plate on, and then once you're done, take the construct down and open the joint and look. And you'll be amazed at how well you've actually done with the joint prep. Because I know that's one of the things that makes people hesitant is that they can't really quite see what the joint surfaces are doing. But if you do flat cuts, you'll see areas of subchondral bone. You'll see some areas of cancellous mixed together, and it's a healthy bed for fusion.
Excellent. That's basically covering the third question as well, Dr. Bailey. Thank you. So the last one here is, am I compromising joint preparation? We hear a lot of folks that are just comfortable. They like the cup and cone reamers. So this is a question we get a lot. And I guess to that end too, it sounds like you look for that subchondral bone line. Are there other ways that you know if you got all the cartilage? I think that's part of this question that we get regularly.
I think I would say start with doing the joint prep with the burr. It's just one small poke hole, and then do the rest of the case open. So you open it up and you get to see, and you'll get better and better, and then they'll help you feel more comfortable switching to the MIS approach. And I think that it does feel a little bit like you're operating in a dark closet to start, but I think that every time you do it, you just get better.
I agree. If you hold the joint distracted and you start with the med head and you finish your debridement with the flat cuts such that you are about a millimeter distal to the medial sesamoid, I found that to be adequate. And then on the phalanx side, you're just looking for that subchondral bone line, which you can see uh, just distal to the articular surface. Um, those are my two little tips. Um, thus far, uh, no non-unions. I have had to remove one plate, and this lady just felt the slightest corner distally over the phalanx where she wore her heels and wanted it out. So I simply removed it, and she's gone on to do well.
Excellent. Okay. All right. And now we'll open it up for questions. So if there's any attendees here that have any other questions, feel free to put those in the chat. One question here, how do I prepare the dorsal surface for the plate? Any tips there?
I do it differently than Erroll, but I actually come through my medial portal that I make at the first MTP joint, and I just sweep the burr over the top coming from that side portal. I do it on both sides of the joint. You can take an x-ray, you can look at it, you can kind of feel it. Once you make your incision, you can reach in there. You're elevating anyway, so you can tell. Most of the time I do a good job at it, but there has been a time where I went in there and the plate, I could just tell the plate was sitting up and I needed to do more.
The reason I go dorsal, it's the equivalent of doing an MIS chylectomy. And I feel safer because I will avoid neurovascular structures. So if you subperiosteally dissect up to the spur and around it and over the top, then you place your burr in the pocket that you created parallel to the metatarsal. Then you go into the spur. Okay, you go into the spur and then you sweep medial and laterally and slightly come dorsally. And you will miss your EHL. You're always in bone. You always want to hear that sound of the burr in bone. And it removes it very, very fast. And then you're going to do that with your C-arm uh, in the lateral plane so that you can see yourself move medially and laterally parallel to the metatarsal and in the spur when you're first resecting. Don't do it from the top down. Go into the spur and sweep medially and laterally.
Got it. That's great. So for somebody that's going into, say, their first MIS plated MTP fusion, what would be your number one tip or number one thing to look out for?
To me, my first uh, issue was I had to learn that one of the difficult things in the joint prep for me was the plantar rim of the proximal phalanx. You have to knock that off. And so with the foot and some distraction with your hand, just make sure that your burr's on the plantar half of the proximal phalanx and you're getting that plantar surface. Because to get a good reduction, you actually have to dorsally translate the base of the phalanx slightly and then pin it. Otherwise, you're going to get a little bit of plantar gapping. You're going to dorsiflex it and you plantarly gap the MTP fusion. So I found that there's a little bit of dorsal translation of the phalanx to get an adequate reduction so that you don't put the fusion in plantar flexion and so that you don't plantar gap it. That was one of the things I had to learn. Also, since I placed my screw from proximal to distal, uh, I want to make sure that I exit in the proximal 1/3 of the phalanx and not any closer to the joint. Because if you do, sometimes that once you drill and put your screw down, you're not completely happy with the amount of phalanx that's left at the base. So I want to make sure that I'm away from that. Those are two tips. Also, to me, when you place your plate over the phalanx, uh, it really needs to be a little more medial on the phalanx than you think, because the plate actually curves a little bit and your screws don't go straight up and down. They actually go from medial to lateral slightly. And if you're medial on your proximal phalanx, you won't hit your cross screw. And that was something that I did once or twice early on.
I think I would just say for me, the most important thing is choosing the right patient. Don't take forever to choose it, but I think making sure it's not somebody that has something super complex, like we've talked about, like a very bad bunion or bone loss, very soft bone. I'd stay away from that. And just like you've said, I think I've switched away from proximal to distal because the bone quality and the amount of bone left at the base of the proximal phalanx at that flare just is a lot less when you do that transverse prep with the joint compared to when we do the cup and cone.
I also think you bring up a good point with soft bone. I have had one where my prep was good. The K-wire placement for the cross screw was good, but my screw got zero bite in the
Mhm.
patient's bone. And then I'm like, okay, now what? Well, I just opened it and 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 uh, and pinned it and put a good neutralization plate that they have in the set across the top. And that one didn't get a cross screw because I couldn't get a bite. But the locking screws held the plate and the reduction very nicely, and she went on to do well. And that's the beauty of this. Uh, this isn't like a mica where you've bought it once you cut the bone, and you just got to deal with it. With this, if you're struggling, you only have one or two little poke holes, you can just simply open it. So you always have a bailout. And that's really nice early in your learning curve.
Yes.
All right. That's great. Thank you both for the points. With that, I'd like to close the webinar. Here's our website if you want to learn more, mismtp.com. Thank you both very much, Dr. Seaworth and Dr. Bailey. That was fantastic. I hope all the attendees enjoyed that as much as I did, and thank you all for joining us. Hope everybody has a great evening. Thank you.
Thank you.
Thank you.